Testing, 1, 2. Testing, 1, 2. First thing, 1, 2. Testing, 1, 2. Testing. Ooh. Testing. Can you hear my words? Can you hear me distinguish my words? Please leave your weapons at the door. Please, I said, please leave your weapons at the door. No, don't say that. It's not the right time. Welcome. We start in 22 minutes.
Sure, John, thanks.
Who's that?
This is Palani here. I'm one of the moderators today.
Oh, good. How you doing?
I'm good, good. How are you, John?
Oh, okay. Can you, let's see, let me get your, let me put my video on and you can do the same.
Yeah, sure.
So we got
Oh, hold on. I think something is wrong with my webcam. I need to
yeah,
unplug
let's
and
fix
plug
it.
it back in.
Okay,
Yep.
let's fix it. Let's fix it.
Yep. All right. Now I'm on video.
Oh, okay. How you doing? Let me get my pin off. Okay, where you, come on, how you doing?
I'm good. How are you?
Can you hear me okay?
Yep, you're loud and clear.
I can't hear you. I can't hear you. Your
Oh
audio is
dear.
not on. So you need
Let
to
me
check your audio.
check. Yeah, just give me a minute. Hello. My audio is okay on my side.
I don't think your audio is even connected. Oh, okay.
Can you hear me now?
I don't know what's wrong with the audio, Kamal. You need to fiddle with it. Turn it on,
Okay.
turn it off, come
Yes.
in, come on. There you go. Turn it on again. Okay, I see it's off. Can you hear? Maybe it's me. Maybe it's me. I don't know.
Okay, can you hear me now?
Oh, wait. Maybe it's me. Hello, can you hear now?
Yep, I can hear you loud and clear.
Oh, good. Okay, it was me. It was my audio. Where are you from,
Pro
Kamal?
I'm from Malaysia.
Malaysia?
Yep.
Oh, great. Are you in Russia now?
No, I'm not in Russia.
Where are you
I'm
now?
still in Malaysia.
Oh, okay. Well, fine. Welcome from wherever.
Yep. Yeah, this is my office in Malaysia.
Oh, good. And how'd you get involved with the group? You're welcome to be here, but how'd you get involved?
I think I was probably one of the earlier ones to be involved with neurosurgical TV with Key Park.
Oh, okay.
Yep. And then I sort of just disappeared from the webinar circuit because timings were all off.
Yeah,
Yep. And then recently I met the main host for today, Nargiza.
yeah.
Yep, and she asked me, would I like to be involved? So I said, okay. So that's how I'm involved with it today.
Oh, okay. What city are you in?
I'm in Kuala Lumpur.
Oh, okay,
Yeah, I met her in Jaipur for ICRAN.
okay. Can you show me in the map?
In the map, yeah, just give me a minute. Let me
Yeah,
just pull
okay.
out the Malaysian map first.
Yeah, okay.
Right. Okay, we share screen. All right, so you can see my
Okay,
screen.
beautiful. Yeah, yep.
Yep, so that's Aussie, that's Malaysia,
Okay,
right? Highlighted in red, and that's Kuala Lumpur, it's the capital.
right. Huge city, right? 8 million or
Uh,
something.
Daytime population is about 5.
5 million. Okay.
Yep.
And what part of the city you in?
I actually
Southern
stay,
part?
um, I'm actually more or less quite central of the city.
Okay.
Not in the central business district, but it's sort of the city, it grows over time, and over time, our residential area seems to be sort of the center of the city, and everything else has grown around us.
Oh, okay. So there's no center of the city. You're not in the center of the city.
Yeah, not the city proper, but everything has developed all around that,
Okay.
it sort of becomes just one big conurbation. Yeah, that's the term they use.
Oh, okay.
Yeah. So Kuala Lumpur, it's actually part of a Klang Valley. It's a huge valley. And the Klang Valley is sort of the most developed part of Malaysia.
Okay.
Yep. So that's where your population of about 8 million is, which is about one third of the Malaysian population.
Oh, okay.
Yep. Ah, Nargisa has joined us already.
Yes. Mhm. Watch for trouble to begin.
Hi, Nargisa.
Hello everyone,
Hello, Nagiza.
how are you? So sorry, I am traveling, so I will
Well,
be with.
wait a minute. Look at Nagiza's changed her look. Hold on. I'm gonna boot you off the screen share, okay?
Hello,
Hello,
John. Hello,
Dr. Kamal.
Nargisa. Are you
Hello,
able to hear
hello,
me?
Anton. Yes, we can hear you.
Hello, everyone.
Hello.
Hello.
Hello. Anton is our new co-moderator today. So from now onwards, he will be helping me with hosting the webinars.
Okay.
He's a neurosurgical resident from Novosibirsk Federal Center,
Okay.
Neurosurgical Center. And for Anton is long way to go, and I think it's a good start to
Okay. Okay.
be a good surgeon.
I'll introduce you first, okay, Nagiza? And then,
Yes, yes,
yeah, and then you introduce Kamal or whoever you
yeah.
want, okay?
We have unfortunately two major problems. So the doctor from St. Petersburg, Ivan Volkov, he got sick. He got some viral infection. He won't be
Okay.
able to join probably.
Oh,
And the second doctor also got viral infection, but from Uzbekistan, he won't be joined. So
okay.
today we're having just three speakers, but that's fine. We
That's
have
fine.
plenty of
That's
time.
fine. I was gonna say to
Mhm.
you, I said, oh, we're kind of pushing it with five, because we got under 2 hours. So,
Yes.
well, actually 3 hours total, but yeah, that's good.
Mhm.
Three's perfect. Perfect.
Mhm. Let me just check how
You
many
change your hair,
participants we
Nagisa,
have.
it's lighter.
Yes, I did.
That's not from the sun.
No, that's not from the sun. 1 second, I'll contact from you guys.
Anton, how you doing?
I'm fine. How are you doing, John?
Good. Yeah, I met you before, I think, Anton.
Yeah, it's a great pleasure to host today in this 10th Russian neurosurgery ground rounds
Good.
webinar.
I'm
Pleasure.
glad you
Thanks.
like it. I'm glad you like
Oh,
it. We've had a very positive response, Nargiza, from Russia. Uh,
Thanks.
it's just doing well. Uh, there's a bunch of stuff going on. You've been very busy, Nargiza, right? A lot of neurosurgery.
yes.
And Anton, are you also in India?
Uh, Not yet.
No, okay. Yeah, Nargiza, you're in India now, right?
No, now I'm in Turkey, but I will be coming
Man,
back to
you're
India in few days.
you're like a wild rabbit. You're hard to keep track of.
Yes.
I don't know
Anton
where you
is
are.
in Siberia. So Anton is doing residency in Siberia, and I hope in the near future he will come and visit us.
Okay, Anton, you're in
I hope
Thailand?
to.
You're Thailand, Anton?
No, Novosibirsk, Novosibirsk.
Novosibirsk
Oh, okay, great, great,
for
great.
time being.
Oh, great, 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 great. That's considered, is that on the coast, Novosibirsk? Is that not on the coast, right?
Yeah, right.
Oh, okay. Okay, we got 10 minutes. I'll be back, okay? Just hang in there. We got 10 minutes, Nagisa.
Okay.
Oh, Nagisa, I'll make you co-host in
Yes,
case you,
please, could you
unless
do
you,
co-host
yeah,
so
unless you
that
need to,
whoever
unless
is
you
joined, I
need
will.
to, have someone join.
Thank you, John.
And Kamal, I'll make you co-host too. Are you familiar with the platform, Kamal, of Zoom? I'm making the,
Hello, Bulat. Good morning.
Hello
Good
everyone.
afternoon,
Hello Nagiza.
everyone. How are you? How is
Uh,
everything?
Everything's fine. Thank you.
Great, great. Hello, dear Dr. Alexander Vladimirovich.
Nice to meet you, dear colleagues.
Nice to meet you too.
Welcome.
Nice to meet you.
First time in our webinars, somebody from Kurgan Center is joining us. It's a great honor.
Okay, Nargiza, so what you been doing?
I'm good. We're waiting for one more speaker, Dr. Mazda Turel. He
Okay,
is about to join. So when he joins, I think we can start.
okay.
So what about Ivan Volkov, Nargiza? We are waiting this speaker.
So he sent me a message that he is also sick. That's why probably he won't be able to join because he has some throat problem. So we have two speakers who are unfortunately out today, but let it be, our other speakers will have more time to present cases.
Okay.
It's plenty. Three is plenty. Three is plenty.
Yes.
But Nargiza gets ambitious, man. She wants to get that. Oh, that's good. That's a nice picture. Where was that?
Sorry, John.
Where was that picture from? You just flashed the
Ah,
picture.
that is from Archaeological Museum from Istanbul.
Oh, really? Let's say it again.
Yeah.
Let's say it again.
This is probably interesting place.
Yeah, it is. But right now I'm not in Istanbul. I am in Cappadocia. So I had fun yesterday.
You're everywhere. Chicken man.
Yeah.
Yeah, yeah, Istanbul sounds like an amazing city. I've just been to the airport. The airport is amazing. It's the first airport I've seen where you can get a bed, you can take a nap. I've never seen an airport like that. That caters to the person with a layover. Because I guess they have a lot of layovers, people that wait and don't have a connecting flight till the next day or whatever. Well, Nargisa, we're trying to get advertisers from the medical device field. to support
Great.
the
Mhm.
webinars. We've been doing it trying to get organizations to pay, but it's very difficult. Most organizations don't have the money now.
Okay, and what
Unfortunately.
about Sanma guys? Are they supporting you?
Yes, well, yeah, they are, because I'm trying to convince them it's a good way to interact with your clients after the webinar. So we're trying to promote that program. I'm going to make a video. I'll send it to you maybe today or tomorrow. Explain the concept of doing advertising for a medical device company. Well, basically what we do is we had a didactic, and it's over. Thank you, Nargisa, for giving the presentation. And now we have the presentation of a medical device from our supporter. So people can leave if they want, or they can hang around and ask questions about the device. The first time it didn't work too good. And we had people just stayed. It was over, and then I introduced the representative. He showed a video of the device, which is an operative microscope, and people to ask some questions. But oh no, people didn't really participate. I said, anybody have any questions? Hoping that get a little interest. And nobody asked the question. So I said, well, okay, maybe we'll try the next webcast. But those are the people that support medical education. They always have. Medical device companies, pharma. So I'm going to try to use that angle because the other way is not working. Societies don't have the money, period. They didn't expect Zoom. It came out of the blue. Okay, we have our other speaker. You have our one speaker to start. Do you want to start, Nargisa, or do you want to?
Actually, I'm waiting for Mazda because he wanted to present first, but let's start off and he can be the second.
Yeah, okay.
Oh, one second. Somebody else is joining. Let me just check.
Yeah, okay. Yeah,
Okay, Mazda has joined. Great.
Rizky, are you admitting him? Okay.
Has joined the meeting.
Welcome.
You are connected to
Great,
computer.
finally.
Hi,
Great.
hi.
Thank you. Hello.
How are you?
I'm
Very
good.
good. Welcome.
We are all
Okay.
good.
Okay,
Welcome.
Nargisa, here we go. Ready?
Yes.
Okay, 10, 9, 8, 7, 6. Oh, wait a minute. Hold on. Let me make sure my televising is fine on Zoom, on YouTube, because we're televising this on YouTube also. Yep, it's fine. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, the home of Neurosurgical TV. We have the honor today of having a very good group, the Russian Neurosurgery Grand Rounds. It's headlined with Nargisa Zartova. She's all over the place. I don't know. It's hard to keep track of her. Right now, she'll update us on where she's at, but at any rate, she's going to be running the proceedings. Okay, Nargisa, welcome. Please introduce yourself and away you go.
Yes. Hello, everyone. It's a great pleasure to continue our webinars. And today we're having our spinal session. It's our 10th webinars, I guess, and it's going well. So today we have interesting speakers and topics. But before we start, I would like to introduce my co-host, and Anton Ivanov is our neurosurgical resident from
Hello, everyone.
Novosibirsk Neurosurgical Center. And also, I would like to introduce our international moderator, Dr. Kamal, the consultant neurosurgeon lecturer in University of Kebangasan from Malaysia. spinal surgeon and pain management doctor from Kuala Lumpur, Malaysia. So let's start from our first speaker. And our first speaker is Dr. Mazda Turel, neurosurgeon, honorary assistant professor of neurosurgery from Grant Medical College and the CIR-JJ groups of hospitals from Mumbai, India. So Dr. Mazda Turel is doing not only neurosurgery, but he's directly connected to art. And he writes interesting short and long stories about the neurosurgical life. So the floor is yours. And today, Dr. Mazda will be talking about minimally invasive sleep.
Great. Thank you for this opportunity to be
Participants can now see your application. You are screen sharing. You have started screen share.
part of this beautiful program, and I'm going to jump right into the topic. I'm audible and visible, correct?
Yes.
Okay. So, MIS surgery has been now around for more than 2 decades, being used very popularly. And, there is a lot of discussion whether things should be done MIS and as opposed to open, whether the decompression is inadequate, whether it's you get effective fusion, whether the technique of instrumentation is safe with the minimal view. And it's important, I believe, to before you decide what you want to do, evaluate your own results and then modify your technique based on your evidence. So there are many, many ways in which MIS surgery can be done. Sometimes it also depends on what you call MIS. A lot of people call a mini open exposure like this through a tube also as MIS. So an MIS TLIF is one of the most robust operations, most commonly performed surgery by any spine surgeon. And, a lot of the times people do it with 2 paramedian incisions. Sometimes there's a single paramedian incision on one side from which the TLIF is done, and then percutaneous screws are put on the other side. Then sometimes you take a small midline incision just for the TLIF and then do percutaneous screws, and you can add navigation and you can add robotics, etc., to whatever technique you're implementing. So all of these ways in which an MIS operation is done is considered minimally invasive, depending on how you do, as long as you're not making a large midline incision and stripping off all the muscle from the bone. This is the schematic flow of events of how a patient is usually positioned at surgery. Most of these patients are obese and they need to be well protected at the chest, abdomen, thigh, elbows, and adequate positioning itself with a good lordosis during the operation results in reduction of alisthesis if there is one. Sometimes there may be a need to do neuromonitoring, but most often we don't use it. The incision, when we do, the way I do it is usually I make 2 small paramedian incisions on either side of the midline and then do the entire surgery through those 2 incisions. Usually you go about 2 finger breadths lateral to the midline, and that's the trajectory you need to enter the pedicle as well. Now, depending on whether you want to do percutaneous screws, it's very important that you get a true AP and a true lateral image. Extremely important that your imaging is absolutely true lateral. And if you're able to see the pedicles correctly, it makes your job very easy. And then you can put in percutaneous screws at multiple levels. You can even dock your tube and do your discectomy, which is primarily the first step of doing an MIS TLIF. You dock the tube at the facet joint, remove the medial facet, do an adequate lateral decompression, remove the ligament, release the nerve root, and then insert a cage. You can see the relationship of the exiting nerve root at that level in relation to the cage. This is what is where the oval is where the tube is docked. This is where your facet comes off, and then you can angle the tube medially and remove the lamina and do a decompression as well. And then you can put in percutaneous screws. It's very important to know the one funda of percutaneous screws is that when you have reach the medial border of the pedicle, you should be at the posterior vertebral line. If you have crossed the medial border of the pedicle and you're still not at the posterior vertebral line, means you're too lateral. If you've reached the posterior vertebral line and still not crossed the medial border of the pedicle, there's a very medial trajectory. So this is a simple rule and a simple principle of making sure you don't have a medial or a lateral breach. You have to identify the pedicle as a tunnel or as a tube, rather than it's a three-dimensional structure. So you have to be able to view it in all three dimensions if you're putting something percutaneously. And that's how you put in your wires percutaneously. And then you can insert the screws through those independent incisions. And you can do this at 2 levels comfortably. You can do 2 levels, 3 levels, depending on how you want to. Sometimes there is a chance that a K-wire may break. As long as it's not transgress the cortex, you can occasionally leave it alone. And this is what the screws look like if they're performed and put in nicely. And then it's easy to pass the rod and connect it. And there are several minimally invasive systems that are available. And this is the end result with a good correction of the listhesis, a good restoration of the disc height, and a good eventual outcome. See, the goal of surgery has to be an adequate decompression and realignment of the spine. Now, however you do it, in whatever technique of minimally invasive spine surgery you use, this is another technique where you do the entire operation through a tubular retractor, where you put in the tube, you do your decompression, you open the tube, and you can do up to 2 levels comfortably through the tube. It's primarily at L5-S1 because the lordosis at L5-S1 is good. So through the tube, you can do if you know 2 people who know what they're doing, then they can do it simultaneously from both sides. So you do a facetectomy, go to the discs, remove the disc, do a discectomy, making sure you go through Camben's triangle, preventing any injury.
Iapod Vads has joined the meeting.
To the traversing and the exiting nerve root. And this gives us a good idea of where we are. Once the decompression is over, you can see that the disc is exposed adequately, the nerve root is exposed, and you can do a discectomy, put in some bone graft, and put your cage, and then insert your pedicle screws later, as we showed you. You can see that the incision is barely 2 centimeters long, 3 centimeters long for a single level, and about 4 to 5 centimeters for a 2-level TLIF. You can see that the heel weld is scarless. This is an immediate post-op scan, and hence you're not able to appreciate the fusion in such a case. This is a lady who had a 2-level problem with severe leg and back pain, severe neurogenic claudication, extremely obese. And you can see obese patients are at a much greater advantage for minimally invasive surgery because the tissue destruction is so much less, and they have a faster recovery. We did a 2-level MIS TLIF for this lady, and you can see how badly she was walking before the operation. And after the operation, you can see a significant improvement in her gait compared to what it was before surgery. And this is just a couple of hours after surgery. It's not like just still. So this is what it looks like, and this is what the incision looked like on either side of the midline. So there's a lot of research, etc., that has been done, and especially in obese patients, where a minimally invasive versus an open approach has been compared. You can see that the blood loss is much less, the incidence of dural injury is lesser, infection is much lesser, and eventually at 1 or 2 years, the outcomes between open and minimally invasive surgery, they even out. But however, the short-term outcomes and the recovery in the first 3 months is much better with a minimally invasive operation. And this is a lady who had 4 previous surgeries, and she had vowed never to have another operation, but she was in such miserable pain. And minimally invasive surgery TLIFs are extremely good for revision cases because you don't enter the previous scar at all. If it's a midline incision, you go laterally, and you can see no one's really addressed the listhesis, which seems to be the problem over here. You can see her scar that was about 1 foot long from her previous 4 operations. They just kept doing something or the other, but we did a simple 1-level T-lift, fixed the spine, and she was okay. Sorry, this is a 2-level T-lift. Sometimes, with dense adhesions and scarring, you may not be able to get into the disc space over here for whatever reason. You may have to. The real advantage of doing this mini open is that you can even do a posterolateral fusion simultaneously. So with percutaneous screws, you can't do a posterolateral fusion at that level. With this approach, you can do a posterolateral fusion, which again is a great advantage. And this is the system setup. Again, you have to do your homework. You have to make sure that the spine is not osteoporotic. If it's not a semi-urgent thing, treat them with teriparatide or denosumab. Make sure there's no issues with bone healing, because eventually you want a good fusion to take place, and identify whether there's a need for contralateral decompression or unilateral decompression will help. This is a lady. People say that it's difficult to do an MIS TLIF if there's a deformity and you're not able to correct a coronal deformity, which is not true in this case. You can see a very steep coronal deformity here in the lower lumbar spine with a hyper exaggerated lordosis, and we are able to correct this deformity with a minimally invasive approach. And like I told you, the advantage is that you can do an interbody fusion along with a posterolateral fusion, and that restores the intervertebral height and gives you an anterior column support. A lot of people, when they do a fusion, they tend to not do a TLIF, but as far as possible, an interbody should be put unless it's contraindicated. This is another patient with severe degenerative disc disease, severe back and leg pain, and you can see the problem at 2 levels, and we are able to fix the problem with, again, a minimally invasive operation, and these scars heal really well. You have to be mindful of exactly, sometimes you may not get the trajectory of the screw correctly because you're operating in a minimum open exposure. And in this particular case, I want to show you that this L4 screw on the right side is pretty much medial and is not the optimal trajectory. So, but let's see if this video plays. You can see that this is the 3 screw, and this is the L5 screws almost going through the canal. Here you can see that this is a badly placed screw. We did not pick this up on the X-ray at surgery. Even though you can see both the screws are of the same height, this screw is 5 millimeters shorter. We should have identified it. We didn't pick it up. I'm going to show it to you. However, luckily for us, the patient did not have any neurological deficit, and he's on a 4-year follow-up with us and remains symptom-free and is playing active football. So it's very important that before the day of surgery, you measure the pedicle size, the screw length, your sagittal balance, you've measured all the pelvic incidences and the pelvic parameters, so that you're not caught off guard during the operation, and don't just take it as another TLIF. This is a patient who's had a previous L4-5S1 laminectomy several years ago, and now has come back with back and leg pain. And you can see the listhesis developing from an open operation done several years ago. Primarily, the stenosis is in the lateral recess. You can see on the right side at L5S1 and L4-5, and good central decompression, but that doesn't solve the patient's problem. Here you can still do, like I said, mini open TLIF from the tube at 2 levels comfortably. This was her walking before the operation with quite severe back and leg pain. And this is her on the evening of the surgery, feeling pretty relieved. And this is a 2-level TLIF can be done with a 4-centimeter incision comfortably. So like I said, revision surgery, extremely gratifying results. So in conclusion, it's a 2-level and a single-level TLIF done minimally invasive are both robust procedures. The data of 1 level can be extrapolated to 2 levels. Blood loss for a 2-level is also now it was originally this much when we started, but now it's reduced considerably. The duration is also reduced considerably. Same-day mobilization, 3 to 4 days of stay. With two paramedian incisions allows for a good posterolateral fusion. And again, now we have long-term data that is comparable to open TLIFs, and now, in fact, sometimes better in certain studies. So thank you very much for your time, and I'm happy to take any questions if there are.
Thank you so much, Dr. Terrell, for perfect and detailed presentation in this difficult topic. Anybody has question or comments from the audience?
You are viewing John Bennett's screen.
Anybody
Okay.
has question?
Any questions from the audience? Thank you very much for perfect presentation. Maybe moderators can give some comments. Okay, maybe questions will come.
It was perfect.
So,
Two questions.
okay. I present the next speaker.
Sorry, Anton. Do you mind me just asking
Okay.
something just to clarify?
Yes,
Right,
yes, of
Dr.
course.
Turrell, was your talk was very lucid, very impressive. I'd just like to clarify something regarding when you first started off, you mentioned that MIS is a minimal view. I wish to have, or I have a slightly differing opinion, and I would like to know what are your thoughts to it as well. So minimal invasive equates to optimal or maximal view with minimal collateral tissue damage. That is how I would prefer to define it. So I'm not sure whether you would agree or you would prefer to disagree on that.
No, I completely agree with your statement. What I was initially saying is that the distinction that some people made between MIS and open, people were saying that MIS surgery does not give you optimal viewings. And that is why they still say that open surgery is better. But I completely agree that it gives you an optimal view because you need to see exactly, you're exposing exactly what you need to see. You really don't need to see more. I was going through the debates on the first slide as to what people said about why MIS should not be considered as to be attempted to be done routinely in all cases because you might compromise the viewing ability. But I agree with you completely that the view is optimal and the collateral tissue damage is negligible compared to an open operation. So you're absolutely right over there.
All right. Thank you. Thank you, Dr. Turrell.
We have one question from the audience. So have you done entry through the midline but go laterally when cutting the muscles fascia?
In certain cases, we used to do that when we started off, but the midline incision then becomes a really long incision if you need to go so lateral, especially if you're doing it over 2 levels. So it really doesn't have that much of an advantage, I feel. When we put percutaneous screws at multiple levels, let's say there's a D12 fracture, and you want to fix from T10 to L2 percutaneously. That's when we put a midline incision in the skin because it looks horrible putting so many incisions into the skin percutaneously. Put a nice, neat midline incision, expose it nicely, and then go through the muscles for percutaneous screws. But just for a single level TLIF, I think these two paramedian incisions look quite cute because the single incision becomes a little longer. Like I told you, everybody has many ways of doing the same thing. The goal should be primarily one of avoiding any muscle damage of the paraspinal muscles or as little as possible, and getting an adequate decompression and realignment of the spine. So if you fulfill those goals, then however you do it, whatever you're comfortable with, I think it should be adequate enough. Does that answer the question?
Thank you so much, Dr. Turrell. More question from audience. So I present the next speaker, Dr. Alexander Burtsev, MD, PhD, Director of Russian Elizarov Scientific Center for Restorative Traumatology and Orthopedics, Kurgan, Russia. Dr. Burtsev talking about pediatric and cervical spine, exploring pathologies and treatment options.
Dr. Burtsov, we cannot hear you. Can you unmute yourself, please?
Could be to able open your presentation, please.
Oh,
Yeah.
I'm sorry. Oh, I'm sorry.
Yeah,
Thank
okay.
you.
Cervical spine pathology is
Oh,
very.
excuse me, we have to put it on presentation mode, please.
When all say present my
At the
presentation.
very bottom, there's options of making it presentation mode. Okay, do you see that at the bottom of the screen?
No, I think he needs to enable editing first. I can't
Okay,
read Russian, but I'm assuming the yellow bar on top, that is to
Okay.
enable editing.
okay.
Yes, разрешить редактирование and then slideshow. Показывать как slideshow.
Так, что мне надо сделать тогда? Я вроде эту демонстрацию экрана включил.
Да, вот где желтая линия, там разрешить редактирование и дальше идти в левый, правый
Okay, it's
угол.
okay,
Ой,
Dr.
sorry, в правый
Bursev,
угол.
if you go down, you can see the 63% there in your screen.
Yes. Или можно увеличить zoom. Yes, you can increase the zoom, which is also
No,
fine. Yes.
just next to it, there's the presenter button there. Just next
What?
to the 80%
Yeah,
on
next,
the left.
you're exactly over there. One of those four
I'm sorry.
options.
Вот
Yeah,
на этой же линии там есть показывать как slideshow. So you can put here.
Да, вот, ну да, я нажал.
Вот.
Yes, that should be the one.
Yes. Окей. So, you see?
Is it showing?
Сейчас видно,
Yes, we
да?
can, but... Да, но что-то почему-то не поменялось. It doesn't change.
А у меня все
Then I think
это...
he needs to enable the editing first.
Yes,
Okay,
вот
go ahead, enable.
разрешите редактирование на желтой линии сверху, которая... Разрешите редактирование, и потом он сделает как слайд-шоу.
Так я ж не вижу такого.
Александр Владимирович, свершите
желтая
презентацию. Да, и желтая линия сверху, разрешить редактирование. Там, где защищенный просмотр.
Сейчас,
Может
подождите.
быть, у вас
Все, вот.
верхняя желтая
Вот
линия,
это.
да.
Ну да, я
Разрешить
и не видел.
редактирование.
И чуть правее курсор. Нет, назад.
Назад. Там есть разрешить редактирование.
Сейчас,
Take your
подождите.
time, we'll get it. No, there's
Да,
no
да, у
hurry.
нас есть
No
время.
hurry. No hurry. We'll get it.
Так, обратно, да?
Нажмите Escape. Нажмите Escape. Да.
И вот там есть разрешить редактирование.
Мне не видно сейчас, подождите.
Ага.
Прям по центру желтой линии.
Все, теперь я не видел этого. Все, извините. Так,
Ничего.
ну,
It never hurts to reboot.
No, sometimes it happens.
опять мне, что ли, да, сделать?
Теперь поделиться экраном.
Ну, я все сделал.
Окей. And then...
So you
just a
can't
second,
click,
we're
you
waiting.
can't click
Видно,
where
что
the
ли, да,
arrow
его?
is.
Now you put on slideshow. Сейчас на слайд-шоу нажмите, вот на слайды, показывают слайды. По-моему, соседняя кнопка. Yes.
Здесь же, правильно?
Да. Ага,
Ну,
должна сработать.
так я так делал.
Yes.
Perfect,
Now
there we
it's
go.
perfect.
We
Now
got
it's
it.
perfect. Супер.
Все?
Да.
Let's start. Yes.
Let's start.
Okay. So I'm sorry, dear colleagues. Cervical spine pathology is very various, and it's due some features, especially embryological features. Just a moment. Anatomical features, partial ligamatosus complex, and biomechanical features in cervical spine have sharp transition with one range of motion to other, range of motion. And some disorders decrease range of motion, but some disorders increase range of motion in cervical spine. As for pediatric cervical spine, each patient have some features: poor muscular development, ligamentous laxity, more horizontal plane of articulation. That's why sometime if we see flexibility, hyperflexibility in cervical spine, it not often signalizate about pathology in cervical spine. At the same time, if we see pediatric patients, you should pay attention about some of external things, especially different stigmatas. And if we see these things, often we may see cervical spine severe surgical pathology in this patient. It's very important things. Cervical spine pathology is very different. We have many different classification, and often spinal surgery have difficult for decision making. That's why we describe syndromatic approach, clinical radiation approach, and if we see one of these syndromes or several syndromes, compression, instability, or imbalance, that's why we see a surgical pathology. If we now detect only one in this syndrome, it's non-surgical pathology. And its approach help decision making in pediatric patients. And the next slide will demonstrate the most common, most interesting surgical pathology in cervical spine in pediatric patients. The most often we may see in upper cervical spine atlantoaxial rotatory fixation. It's imbalance syndrome. It's a condition due different reasons. And sometimes we use hollow west remodeling therapy, but most often we used posterior screw reduction and fixation with or without preliminary hollow traction. Hollow traction in pediatric cervical spine, very nice, helpful option. So sometimes in pediatric patients, atlantoaxial rotatory fixation due to different anomaly. But tactic in this patient similar posterior screw reduction and fixation. Next group is different type of atlantoaxial rotatory atlantoaxial dislocation, and each patient have compression with or without instability. Moment. Sometimes atlantoaxial dislocation accompanied with rotational component, and we may see compression with imbalance syndrome. But in these patients, we also use posterior approach, screw reduction and fixation, similar with or without preliminary hollow traction. Next type of disorders, os odontoideum, but not always pathology accompanied with instability. But sometimes in MRI we may severe things, myelopathy example, or big deformity with severe spinal cord compression, and we also performed posterior approach with C1, C2 fixation with or without preliminary color traction. Next group, it's different type of basilar invagination. Atu Gael described the 3 types of basilar invagination. In these cases, we may see always compression and sometimes with or without instability. Sometimes basilar invagination accompanied with atlantoaxial dislocation or other conditions, example, Chiari-1 malformation, but always in these patients performed posterior reduction, indirect decompression, and screw posterior fixation. Next group in pediatric cervical spine is severe cervical kyphosis due to different reasons, example, abnormalities or different syndromes. But in all of these cases, we see compression syndrome. We may see severe spinal cord compression, sometimes with neurological deficit, sometimes without neurological deficit. But in all of these cases, we used posterior approach or combined approach for direct and indirect decompression and fusion. But sometimes these patients have postoperative complication, and we should perform revision surgery. Sometimes we may see, as this case, severe deformity, kyphosis with cervical stenosis, and we need to perform multi-step, high riskly for patient surgery. Next group of pathology in pediatric cervical spine is different cervical stenosis. It's similar syndrome compressions. It's condition due different reasons, most often accompanied different dysplasia, polysaccharidosis, and other systemic disorders. But also in these patients, we performed posterior decompression and posterior screw fixation. In cervicothoracic region, sometimes we may see severe deformity, imbalance syndrome due to neurofibromatosis, and we performed posterior partial correction with stabilization, but sometimes in intraoperative we have we may have technical pitfalls in these patients. Cervical spine abnormalities, example, triple fail syndrome, provide instability or instability with compressions, and we should perform decompressive and stabilization in different with use different approach. Sometimes we may see natural abnormalities, example, lateral hemivertebra. Sometimes it's accompanied without external things, but if we choose conservative treatment in the future, we may see as develop of severe deformity in these patients. That's why sometimes we should perform prophylactic surgery for arrest progressive deformity in cervical spine. Very interesting group of patients with trauma, not often, but one of the feature in this patient is high instability in these cases. Example, this case with an unstable joint fracture, or this case with similar Hanuman fracture, and we need to perform circular stabilization. And sometimes we may see cervicothoracic injury with high instability, and we should perform also circular stabilization in these patients. As for instrumentation trends in pediatric spine, most often we use posterior fixation with a screw device, and rare with different laminar fixation. A bit about technique in C1, most often used lateral mass screw fixation, and in this patient we may choose different subtypes of screw insertion, and it's depend of anatomical features. Example, abnormality of vertebra artery or pica, or particulus posticus in C1, or big plexus venosus in C1, C2. In C2, we may use four type of screw insertion: transarticular, Sibler-Magyar, intralaminar fixation, very easy and very safe methodic. Most often transpedicular, very nice methodic, and sometimes you may use or we may use pars interarticulars methodics. In subaxial cervical spine, most often use lateral mass fixation, very safe, very easy. Next, interlaminar fixation, rare use, most often in C1 level, C7 level. And the most good methodic is transpedicular screw fixation. It provides high rigid fixation. All of method of screw insertion we may separate about three categories. The first, a different type of free hands. Next, with help 3D printing, and with help CT navigation. A bit about the 3D printing. We may use intraoperative guide template or 3D models, or combination with 3D models and templates. It's help correct insert screw. After the screw insertion, if we use different type of insertion screw, you may use different type of installation construction with use of 3 roots construction, especially in the transitional zones, crânio-cervical or cervico-thoracic region. Sometimes we may use connectors or transitional diameter roots if we used a different type of screw, for example, cervical screw and thoracic screws. Sometimes if we have aplasia or hypoplasia vertebral artery in one side, we may use combination transpedicular and lateral mass fixation. Example, in site when we have vertebral artery hypoplasia, we safely most may use transpedicular fixation, but in contralateral side, we may use lateral mass fixation. And sometimes if we use put screw in interlaminar in situ, you may installate cross installation of roots. So in conclusion, pediatric cervical spine pathology is very various and difficult for decision making. Understanding basis pathology is key of the right treatment. Knowledge of technical features, fixation, advantages, and disadvantages provide successful treatment of pediatric spine. Thank you very much for your attention. You are welcome in Elizarov Center. Thank you very much.
Thank you very much, Dr. Alexander Burtsev. It's a great presentation. I just want to give a small comment about this huge center. So being a director of this huge center, you got the time for our webinars. And one more time, thank you very much. I was honored to be your fellow in 2020, and I saw the number of patients, the number of surgeries you are proceeding, and this is the great. I just want to tell international audience that Elizarov Center has, I think it is the biggest orthopedic and traumatology center in Russia. They have 13 traumatology and orthopedic departments along with neurosurgeons. They are doing a lot of cases, and it is all about teamwork. When patient come with primary disorders, apart from vertebral disorder, they have some orthopedic issues. So the team work very smoothly, and I was impressed, and I was glad to have lectures and education from this center. Thank you one more time.
Thank you very much, Nargiza.
Thank you a lot, Dr. Burtsev, for presentation. It's believed that pediatric spinal neurosurgery faces more complex and rare cases. Any question or comments from audience? It's interesting topic. Have a question?
Okay, if question
sorry,
comes, you
I
can
don't understand your question. Your question
no,
or comment?
so far there is no questions. So if any question comes, you can anytime type, and I will read. So somebody can type the questions. I will read it after our webinar.
Okay.
Oh, yes,
sorry.
sir. Yes, sir.
Yep.
Okay.
Just a question to you, Dr. Burtsev. How often do you do a dynamic MRI or a dynamic CT? Do you find it useful in your practice, especially when it comes to CV junction? Because sometimes, they tend to have symptoms, but when you do a static imaging, be it the MRI or a CT in a supine position, you're not able to see this impingements. So do you find a dynamic imaging, be it in flexion, extension, or in rotation, and then doing the MRI instead of a standard supine position? Do you find any value in it? Because I feel that you've done a lot more, many more cases than what I've done.
Yes, in our practice in adult patients and in pediatric patients, sometimes we used dynamic CT, especially in pediatric patients with atlantoaxial rotatory components dislocations, or not understanding torticollis in these patients. And sometimes we use flexion extension MRI for diagnosis of stenosis or spinal cord compressions. Dynamic MRI, most often we use in adult patients. and CT with rotational imagination we use in a pediatric patient most often. It's very nice options for diagnosis.
All right, thank you for your wonderful explanation.
More question?
Comments
So-
maybe. Okay, one second. We have one more question from audience. Just a
Okay.
second. So Hitesh Kumar is asking, youngest age when screws can be put in C1 and C2. Any experience of hooks in pediatric cervical spine?
In our practice, we most often use screws fixations. Very rare we use laminar hooks, especially in craniocervical spine. I don't remember the last case when we used laminar fixation. We have not bad experience. Our team good performed this type of fixations. And in our clinic, we have CT navigation. And it option very help for insertion, especially in very difficult cases with different abnormality and other cases.
Okay. We have one more question from the doctor from Afghanistan, Dr. Pirzad. He's asking, excellent presentation. Do you advise external support in SCI instead of surgery in low resource centers?
External, sometimes we in postoperative period we used different type of collars, but after posterior fixation we may have high risk infection complication when we used collars, example Philadelphia collars in all time after operation. It's not good aspects, but sometimes yes we use.
Thank you.
Okay, thanks a lot, Dr. Burtsov. So we can move on the next topic, and next speaker, Dr. Bulat Kinzagulov, MD, consultant neurosurgeon of Neurosurgical Department of National Medical and Surgical Center named after Inai Pirogov, Moscow, Russia. Dr. Bulat talked about dependence of the radiological severity of lumbar spinal stenosis on functional disability and pain before and after surgery.
Thank you. Good afternoon, everyone. The importance of lumbar spinal stenosis is beyond any doubt. I think, in fact, it is one of the most common indications for surgery in patients over 65-year-old nowadays. And everyone knows that diagnosis is established by summation of clinical data and instrumental methods. And one of the main diagnostic tools is MRI. It is gold standard nowadays. But how we can classify lumbar spinal stenosis using MRI? And if we can, is there any association between radiological severity or extent and clinical manifestations or even outcomes? According to many other spinal pathologies like spinal trauma or spondylolisthesis or oncological diseases, we have many classification systems. In some cases, we can use them as a guide to choose one or another way of treatment. Furthermore, we can predict the clinical stages of patients just using different classifications. The most popular MRI classifications according to lumbar spinal stenosis are Shields and Lee classification systems described in 2010 and 2011. respectively. I think they are well known among spinal surgeons, and we use one of them or both in our everyday practice. However, we should ask a question. Can we use these classifications as a decision-making guide? Or, by the way, can we say anything about clinical manifestations of patients just assessing severity of lumbospinal stenosis via MRI? Or maybe we can prognose the outcomes. To answer many questions, let's have a look at the literature. And the first study was about predicting low back pain with electrophysiology and MRI. Authors said that they really found a correlation between electrophysiological testing of with size of spinal canal and clinical manifestations. And the second one, similar results. Here, authors stated that MRI grading system can correlate with obstetric disability index. Another two studies, there were correlations between neurological impairment score, SHISAS, and between dual cross-sectional area and claudication and obstetric disability index. And on the other hand, in some articles, authors found no correlation between walking distance, ODI, leg pain, and canal cross-sectional. And another example of no association between disability, pain, clinical outcomes 1 year after surgery and radiological severity. Well, unfortunately, we couldn't make a conclusion according this topic, this problem, because of small sample sizes of those studies and even contradictory results. Moreover, there's lack of studies of association between extension of lumbospinal stenosis and functional outcome, functional status. So we decided to make our own research, and objective was to assess the association between radiological severity of stenosis and its extent on clinical data. We completed a retrospective cohort observational study and included all the patients with clinical significant lumbospinal stenosis. We excluded patients with significant comorbidity, like rheumatoid arthritis, Parkinson's disease, etc., and previous surgical treatment of spinal pathology. We enrolled 380 patients, and distribution of severity by severity and extent you can see on the screen. There are lots of patients with SHISAS C and D, not so many patients with SHISAS B. There's no patients with Lee first grade, because Lee first grade is similar to SHISAS A4, I think. So we enrolled all patients with Lee second and third grade. And we assessed clinical manifestations using questionnaires like obstetric disability index and visual analog scale. They are on the screen. And now on the slide, you can see the first results of scores, and there are not many differences between visual analog scale and ODI between SHISAS and Lee grades. But what about statistics? Comparing the visual analog scale and ODI according to the SHISAS classification, we found no statistical significance by using Krasker-Wallace and Vask-Steele-Critchlow analysis. Also, we found no difference comparing visual analog scale and ODI according to Lee classification. No statistical significance. Furthermore, there were no significant differences according to extent of lumbospinal stenosis before surgery. We built a correlation matrix. We used Spearman method, and we had no correlation between the ODI, visual analog scale, and extent, or even translation of vertebrae in cases with degenerative spondylolisthesis. Then we performed the same analysis for cases after surgery. We include the data from 146 patients with median follow-up 23 months. We found interesting correlation between number of affected segments and ODI score after operation. Then to prove our statistics, our analysis, we used linear regression model and noted that there's significant difference between ODI scores in patients with 1 and 2 level stenosis. Only in those cases, only in 1 and 2 level stenosis. So we can say that, in our opinion, the degree of lumbospinal stenosis assessed according to Jesus and Lee MRI classification systems, as well as a number of affected segments, did not significantly influence on degree of functional inadaptation and PMSVT. But we should state that there is statistically significant difference in ODI scores between patients with 1 and 2 affected levels after surgery. Thanks for your attention. Thanks for invitation and this opportunity. Thank you, Dr. Bennett, Dr. Saatova. Thank you very much.
Thank you very much for your nice presentation, Dr. Bulat. Dr. Bulat is with us second time, and every time it's something new. So any questions and comments from the audience? Okay, let me check the questions. No questions. Sir, Dr. Kamal, maybe you can give some comments.
No, I mean, I think it's a very good and innovative study whereby you can actually try to predict symptoms based on radiology. Usually we predict the radiology based on symptoms. So I think that is something good and novel, I would say. And let's hope we have more people trying to replicate it. Hence, we can actually have more evidence to support, and perhaps we can come up with Bulat's classification as well.
Maybe, yeah.
Yeah, why not?
Sometimes in the future, yeah.
Today's the start.
Mm-hmm.
Yeah, you always have to start from somewhere.
Of course.
Right.
Thank you very much. Thank you.
Hey, very good, Nargiza. Are you ready to wrap it up, you think?
Thank you. Also today we have Dr. Jakub.
Oh, okay, I'm sorry.
From Georgia, who was with us. Maybe Dr. Jakub, you can give some comments, and Dr. Karem Rodriguez, could you introduce yourself, please? I think you are our guest today, if they are here. Otherwise, all topics, they went well. I am very glad. Usually, spinal session is something which everyone does, but not everyone know how to do it correctly. And I am glad that today we could gather super guys and super mentors who can teach young neurosurgeons how to make a decision, first of all, how to go for the case and when not to go for these cases, and when operate or
Yeah. Okay, we're losing you, Nargiza.
wait and watch.
Okay.
But I just want to tell that our next webinar is 21st of April.
Okay, I guess we'll have to, we're losing you, Nargiza. We can't hear you.
It will be a skull-based session. So whoever wants to participate or invite friends, internet connection. Can you hear me now?
Yeah.
Can you hear me now?
Yes.
Now it's okay, right? I just want to tell that our next webinar is going to be 21st of April. That will be skull-based session. Whoever wants to participate, and invite friends or surgeons, young neurosurgeons, most welcome.
Okay, very good. I'd like to thank everybody. I'm not a neurosurgeon, but let me just tell you something about webcasting. One of the advantages of this platform, Zoom, is that we can get to know each other and see each other. I noticed a few of you went right into your presentations, which is fine. However, I think it's good to establish a bond with the community, showing your face. And when you presented, I didn't know who was presenting. You're branding yourself. You're young. You want the neurosurgery community to know you. And the way to know you is your face. It's a great way. I mean, this is a great technology that we're able to, on a Sunday, have a good conference from Russia and other parts of the world. And we want to bring personality to it. Us, we're not reading a book. We're not reading an x-ray. We're people talking to each other. This is the fantastic thing about this platform. So don't be afraid to, when you introduce your presentation, is, hi, I'm John Bennett. I'm from Miami Beach. I'd like to get to know you guys. We're a different part of the world, and I want to learn. It doesn't hurt to get to know people. And it's certainly a pleasure to meet Nargiza. She's hard to follow, man. I get dizzy trying to watch her travel around the world. And I thank all you guys for spending the time and making this a great great webcast. And we'll see you hopefully before April. Okay, thanks everybody.
Okay. Thank you very much. Thank you.
Thank you, guys.
Thank you, Dr.
Thank you.
Khan.